very fine good evening to all. Welcome to IB class Genesis series. Today we are having session 3 on the topic neonatology, and it's my privilege to invite Dr. Mohandas Nair sir, additional professor, Department of Pediatrics, to take us through the section. Welcome to the session, sir. And as always, audience can post their doubts in the comment section. So let's begin. Sir, handing over to you to proceed with the class. Sir, please.
Good evening. It is a very happy moment that that Information Bureau is organizing such academic programs, and I came to know that you already had 2 sessions. First was on the anatomy of pelvis, and next was regarding the process of normal labor. So it is a continuum. Through pelvis, a baby is being born, and then comes the area of neonatology. Neonatology being a very fascinating field where we can make a significant difference if we act in the right time. And if you fail to act, it can lead on to a lot of life of the child, in the quality of living of the family, and also for the society. So with this introduction, let me share my screen. Can you see now?
Yes, sir.
Yes, sir. Yes, sir.
Okay. So today we will be discussing on care of newborn. Care of newborn, that is care of a newly born, to be apt. That is the immediate care of a newborn baby. So as I have already mentioned, this is one of my favorite quote. I have mentioned, probably I have already mentioned this to you, the quote by Gabriela Mistral from Chile. Many things we need can wait, the child cannot. Now is the time. His or her bones are being formed, blood is being made, and mind is being developed. To him, we cannot say tomorrow. His name is today. Not even today, the topic which I am going to discuss, you will understand it is that particular moment, that particular second. So time in case of a newborn is counted in seconds. As you all know, newborn period is the first 28 days of life. And so when we discuss about the under 5 mortality, this newborn period, first 28 days of life, comprises only 2% of this first 5 years, but almost 60% of deaths occur in the newborn period. So you know how fragile a newborn is. So you have to handle with the care. Early neonatal period is the first 7 days, or more than 2/3 of the deaths occur in the first 7 days. Among all the neonatal deaths, more than 2/3 occur in the first 7 days. And the major cause of mortality in a newborn will be preterm, prematurity and its complications, bacterial infections called as sepsis, birth asphyxia or perinatal asphyxia, it is all aptly called, and various congenital malformations. So, as already mentioned, the asphyxia, perinatal asphyxia being an important cause of neonatal mortality, and your timely intervention is going to decide the quality, whether that baby should live or not, and also what should be the quality of life. So, if you learn neonatal resuscitation properly, that will be a very useful, or you will be very much satisfied if you could use that knowledge in the correct situation. Because it is totally different from saving a 70-year-old adult from an MI, where you will be giving 1 or 2 more years to his life. Whereas here, in case of a newborn, you are giving the entire life. So 25 million infants are born in India every year, and 3 to 5% experience asphyxia. So what is asphyxia? That there is a lot of difference between intrauterine life and extrauterine life. Just like you may be experiencing, Albin is there. Till now, you may be getting whatever you need from your parents, and once you become house surgeon, you will have to find out the earnings from your own. Like that, a newborn till birth is dependent on the mother for all the needs, and once the baby is out, baby has to do it all by itself. So if the baby cannot adapt to the extrauterine life, the baby will develop progressive hypoxia, which can start in utero also. If there are the uteroplacental problems are there, it can start in utero, and progressive hypoxia will occur. Hypercapnia, the carbon dioxide concentration will increase, and once the hypoxygen is an important thing which needed for all the activities. So even the myocardium will start functioning poorly. There will be hypoperfusion, and it leads on to acidosis, and this affects all our organs. So it leads on to multi-organ dysfunction, which can lead to death. So the most severely affected organ due to asphyxia is brain, and the second organ will be kidney. So hypoxic ischemic encephalopathy it is called, and it can lead on to serious neuromotor sequelae. You might have seen children having cerebral palsy. One important reason can be perinatal asphyxia, but you should not have the belief that all the cerebral palsy are due to hypoxic ischemic encephalopathy. A small percentage of cerebral palsy are due to hypoxic ischemic encephalopathy, but this aspect is actually preventable, and you should do whatever is possible to prevent this sequelae. So to prevent hypoxic ischemic encephalopathy, what you have to do is you should acquire skills. What all skills you need, I will come to that. And you should anticipate. When should you anticipate? So that also you should know. And you should be ready to act. And you should ensure a good teamwork. It is not a one-man show. A proper resuscitation is a teamwork, and only a team will succeed, not an individual. So regarding pathophysiology of asphyxia, when the baby is deprived of oxygen, initially the baby will breathe fast. When asphyxia continues, baby will develop apnea, which is called primary apnea. As I have already mentioned, this can happen in utero. So once the baby develops this primary apnea, heart rate begins to fall, the muscle tone decreases, and the BP at this time is almost normal. So just tactile stimulation. So if baby happens to be born at this time, just a tactile stimulation is needed to reinstate breathing. But if this apnea continues, the baby starts taking deep gasp, heart rate decreases further, BP begins to fall, and the infant becomes flaccid. And again, baby develops apnea. So initially baby developed apnea, after that baby, the asphyxia continued, baby started breathing, gasping breathing, and again develops apnea. And this apnea, which happens for the second time, is called secondary apnea. And this apnea is unresponsive to stimulation. You need a resuscitation, where you have to go through all the steps if you could save the baby. Unfortunately, when a baby is born apneic, you cannot differentiate whether this baby is in primary apnea or secondary apnea. So it is always better to think that baby is in secondary apnea and start resuscitation rather than waste your very valuable time thinking that it could be primary apnea and baby will come around without any intervention. So always when a baby is born apneic, consider that it is secondary apnea. Once you start resuscitating, retrospectively you will know whether it was primary apnea or secondary apnea by assessing how much resuscitation you needed to uh, lift the baby from the problem. So, okay. So, there needs a lot of preparation for resuscitation. So, what you see, the actual process of resuscitation is the more important part happens before birth of the baby, that is preparation. If you, by failing to prepare, you are preparing to fail. This is apt not in the situation of resuscitation, but for everything which you needs preparation. Definitely, I am mentioning your examination. If you are not preparing, you are preparing to fail. So start preparing. 50% of asphyxia could be like a bolt from the blue. That is, you cannot predict which baby is going to be asphyxiated. Usually, I have seen so many parents saying, so all the tests were done, whatever scans were done, and even then my baby is like this. And they are waiting for some words from us saying that the obstetrician is the cause, but it need not be like that. So in certain cases, you cannot predict which baby is going to be apneic. Of course, there are certain situations where you can anticipate. So the thing is, in all places where a delivery take place, sometimes it may be once in a month. In certain hospitals, delivery may be so infrequent, once in a month or so, or once in 2 months. Even then, there should be all the facilities for resuscitating the baby. So there should be a trained personnel available. Equipment should be in working condition and it should be kept well arranged and ensure good teamwork and communication. So I was mentioning about acquiring the skills. The skill you need, one is teamwork. I need not mention anything about teamwork. You all know how important it is to have a good teamwork. When you are having a union, college union, it cannot run the union work by the chairman or secretary. So they should involve lot of people in the activities. So only the team will win. And another thing is there should be a good communication with team members. The team member should not feel that the person who is asking to do something is the boss and other one is a subordinate. There is nothing, in a team there is no boss or subordinates. All should be equal. Or in the communication, you should not have the feeling, should develop a feeling of bossing. And you should know how to communicate properly with the relatives also. And you should know how to take proper decisions in certain situations so that we will be coming. And apart from that, these skills you should acquire. One is how to give positive pressure ventilation. Out of all these skills, the initial 3 are very important. Apart from that, the other 4 skills which I have mentioned, if you ask me what is the most important skill, I will say it is to know how to give positive pressure ventilation properly. So if you perform that step appropriately, the other steps may not be needed in most of the situations. And then it will be chest compression, how to give chest compression, then how to intubate the baby, and how to cannulate the umbilical vein to administer medications. These are the 4 important skills you should acquire to successfully resuscitate a newborn baby. Among these skills, I will be mentioning only about the how to give a positive pressure ventilation and chest compression. Intubation and umbilical vein cannulation are very difficult to teach in this way. Apgar score, I am not going to mention more about Apgar score. You will be knowing how to score. And the first Apgar score will come at 1 minute of life. And next it will be at 5 minutes. So, as I have already mentioned, asphyxia, you can just imagine a situation when someone very powerful has caught your head and immersing you in a bucket full of water. You are struggling to breathe. So at that situation, can you wait for 1 minute? Let the first Apgar score to be out, then I will start resuscitation. So it is not possible. So Apgar score is not something which decides whether a baby needs resuscitation or not. But the response of your resuscitation can be assessed by the Apgar score. And long-term effect, long-term sequelae can be compared with how the Apgar score was at 5 minutes or 10 minutes like that. Other than that, to decide what to do, how to resuscitate, Apgar score is not important. That doesn't mean that Apgar score is not important. It is a very important score which will predict the long-term outcome of a baby. And so some of you might have already been in our labor room. You might have seen how babies are being resuscitated. So usually one person from neonatology unit will be there. And as you all know, that person alone cannot do things. One house surgeon will be posted in our baby room. So that person also forms part of the team. One staff nurse will be posted there. And that also is part of the team. Apart from that, you should have a good communication among other members in the labor room so that when there is a need, all should come to help you. For example, when there is a twin delivery, both babies are asphyxiated. These 3 persons cannot do everything. So you need help from others. So you need to know how to call for help and they should be ready to help you also. So it is very important to have a very good relationship between your colleagues wherever you work. Apart from that, there needs equipments. And a good team cannot win if you don't have the equipments. So the important aspects, one thing will be to maintain the body temperature. So various things you want will be, one is radiant warmer. You might have seen radiant warmers. So when you are anticipating a delivery, you should switch on the warmer at least 10 minutes in advance. And you need pre-warmed towels. See, a newborn is coming to this world. So whenever a person is coming, who is very important is coming, you will give a warm welcome. So for a newborn baby, you should be ready to give a warm welcome. So warmth is it should become like this with a radiant warmer which is switched on at least 10 minutes in advance, and you have to keep 2 towels over the warmer so that it will get heated. And in case of preterm babies, you will deliver the baby in a polythene bag so that evaporation is one important mean for losing our body temperature. So to prevent evaporation of the liquor, the baby will be delivered in a polythene bag. Just head is kept outside. You don't waste time to dry the baby. In case of a preterm, they are highly prone to develop hypothermia. Then to maintain airway, you know the term TABC, temperature, airway, breathing and circulation. So to maintain airway, you need mechanical suction. So mechanical suction the suction pressure is very important. You know, these newborn babies are very delicate. And you should also know that the most important protective barrier or protection from infection is an intact skin and mucous membrane. So as far as possible, you should not breach the intactness of the skin and mucosa. So a vigorous suction can cause mucosal damage. So you should adjust the suction pressure to 100 centimeters of water or 80 millimeters of mercury. So that is the suction pressure allowed. So you should adjust it beforehand. And you should have suction catheters of various sizes, laryngoscope blades of 0 and 1 size. 0 size is for preterm and 1 size for term babies. You should have extra bulbs. Sometimes the bulb may not be okay. You may have to change the bulb. And you should see that the bulb is tight. It should not fall into the throat of the baby when you are trying to intubate. And the batteries should be should not be very weak, good battery. So you should see that the endolaryngoscope is having good light before delivery. Endotracheal tubes of different sizes, 2.5, 3, 3.5, and 4 sizes. And shoulder roll. I will come to the importance of shoulder roll. And gauze to clean the oral cavity. And regarding breathing, you need ambu bag to give a positive pressure ventilation. Other things which can be used instead of ambu bag is a T-piece resuscitator. I am not going to discuss about that here. That is much better than the ambu bag, but costly. Feeding tubes, I will tell how it is important. Pulse oximeter and probe. You should know what is the oxygenation status. You should be able to adjust the oxygen flow, so there should be oxygen with the flow meter. Because oxygen is a drug. For every drug, there is a dose. For oxygen also, there is a dose. You should adjust. If the oxygen is more, that also is harmful. So it should be measured. You should never give oxygen unmeasured. Then to improve the circulatory status, you need medications like epinephrine, normal saline, to administer the syringes, needles, umbilical catheter, stethoscope to assess the heartbeat and all, 3-way stopcocks, gloves, ECG monitor. So all these should be kept ready before the delivery take place. So you should ensure that all these are there, all are in working condition, and you should know where these things are kept. You cannot search for things when the baby is already born. So you and your team members should know where all these things are kept. It should be within your hands reach. So ensure availability, equipment check, and arrange it in an order so that you should get it when it is needed. But doesn't think that all these things will be needed when a baby needs resuscitation. So most of the babies, you need to give the routine care. More than 90% of the babies, you need to provide routine care. There is no need of resuscitation. But a small percentage, 5 to 10%, may require the initial steps of resuscitation. I will come to that, what is initial steps of resuscitation. And probably 1 or 2% of babies will require a positive pressure ventilation and chest compression and other full steps of resuscitation. So that is why I was mentioning the most important skill you should develop is how to give positive pressure ventilation appropriately. That will reduce the need for further steps of resuscitation. And this is the algorithm. So even antenatally, you will be counseling the mother and the relatives, the parents. You will be saying that what all problems you are anticipating, and you should say we have a good team and your baby will be safe in our hands. We are ready to do whatever is possible once the baby is born. So you should instill confidence in the parents before birth of the baby. And once the baby is born, and you have to discuss among the team members, and there should be, even though there is no boss or subordinate and all, there should be a team leader, definitely. And you should delegate the duties beforehand. For example, you should say, once the baby is born, I will be in charge of the initial steps, and I will be in charge of giving bag and mask ventilation. If by that time you should entrust the other person, you should be in charge of checking the heart rate and all, and you should be the person who should attach a pulse oximeter, and you'll be in charge of giving chest compression. And the third person will be in charge of umbilical vein cannulation if it is required. So like that, intubation. So like that. So you can delegate the duties beforehand, so that there should not be any confusion once the baby is born. And once the baby is born, you should ask these 3 questions: whether it is a term gestation, whether baby is having good muscle tone, whether baby is breathing or crying. So these are the 3 questions you should ask: whether baby is term, whether there is good muscle tone, whether baby is breathing or crying. So baby is in your hand, and you have asked the questions, and if the answer to all the 3 is yes, the infant stays with mother for routine care. So warm and maintain normal temperature, position the airway, clear secretions if needed, dry. And you should evaluate, ongoing evaluation. If any answer to any of the question is no, then you take the baby to the resuscitation corner, warm the baby, maintain normal temperature, position the airway, clear secretions if needed, dry the baby, and stimulate. These are the initial steps of resuscitation. And this will be completed within 30 seconds of birth, and you have assessed the baby by that time, whether the baby is apneic or whether baby is gasping, and whether the heart rate is below 100 per minute. If these things are not there, baby is not having apnea, baby's heart rate is more than 100, but baby is having some labored breathing or persistent cyanosis. In that case, baby needs positioning, clearing the airway, SpO2 monitoring, supplementary oxygen as needed. Consider continuous positive airway pressure. But if the baby is apneic or gasping, you have to provide, or if the heart rate is less than 100 per minute, you have to provide positive pressure ventilation. You have to see what is the pulse oximetry readings. Consider ECG monitoring also. So this much is the initial part of resuscitation, and then next part I will discuss later. And you should know what is the expected SpO2 readings after birth. You cannot expect 100 SpO2 reading in a newborn baby who is just born. At 1 minute, normal will be around 60 to 65%. 2 minutes, so you can add 5 to each. 2 minutes, 65 to 70. 3 minutes, 70 to 75. 4 minutes, 75 to 80. 5 minutes, 80 to 84. And at 10 minutes, it will be 85 to 95. So that is how the oxygen saturation increases normally after birth. So you have to give oxygen based on the expected SpO2 value and what is actually seen in the baby. So we have gone through all these things: term gestation, hooked on breathing or crying, and so now I will stop sharing the screen. Hello, can you see me now?
Yes, sir.
Okay, so Is it clear whatever I have told already? Hello?
Yes, sir. Yes, sir.
Okay. So we will see how these things are done now. I don't know how clear it will be. We will try. Okay. Can you see me?
Yes, sir.
So here we have a baby. Can you see the baby?
Yes, we can see, sir.
So this is a baby. This baby is just delivered, and uh, so you are at the delivery point, and the baby is on the hands of the obstetrician, and you will be asking what all questions. Can someone say what all questions you will ask? Wafa?
Hello, sir.
Is it a term gestation?
Is it a
Does
term
the baby
baby?
does the
So
baby
this is
have
a
good
term
muscle
baby.
tone?
This baby is having good muscle tone, and this baby is breathing and crying. Okay. So if the answer to all the three questions were yes, so what you have to do is you just keep the baby on mother's abdomen. You need not take the baby away. You can wait uh, for 1 minute at least to cut the cord, because some more blood will come to the baby, which will increase the iron store of the baby, and that will prevent further development of anemia. In case of a preterm baby, if you are waiting, uh, if you are delaying umbilical uh, cut down, cutting the umbilicus, so not cut down, if you're clamping the umbilicus is delayed, that will reduce the chance of intraventricular hemorrhage to that baby. So there are several advantages for delayed cord clamping. So you should not deny the benefit to the baby. So if the answer to the three questions are yes, you can delay cord clamping, you keep the baby on mother's abdomen, and you proceed with the initial, not the initial steps, the routine care. The routine care will be, you will be drying the baby, keeping the baby on mother's abdomen. You will be removing the towels, and you will be clearing, if there are some secretions, you will be clearing it with a gauze piece. You will be cleaning the eyes with another sterile gauze piece. Uh, After 1 minute or so, you will be cutting the umbilical cord. You will be keeping the baby on mother's chest, and the baby will start breastfeeding then itself. Even within few minutes of birth, baby will start breastfeeding. Whenever you are asked when should a baby be breastfed, you will say as soon as possible. So what is as soon as possible? It is immediately after birth. If baby is otherwise no. So you should so early initiation of breastfeeding, and so the baby will be convinced at that time that baby is okay. A lot of stress is mother is relieved of her stress, and once the baby feeds, another advantage is that the oxytocin is secreted in the mother, so that it will reduce the chance of postpartum hemorrhage. It will help in the separation of the placenta. So that is the routine care of the baby. But if the baby is the answer to the question, at least one of the question, the answer is no. Baby needs uh, some assistance. So such babies are immediately taken to the resuscitation corner. Baby will be placed on the radiant warmer. As we all know, radiant warmer is already switched on at least 10 minutes in advance. And you should see that you know how the heat is lost from the baby, and you should take adequate precautions to see that the heat is not lost in any means. So you should be keeping the windows closed. You should be switching off the fan. You should be adjusting the labor room temperature to at least above 26 degrees centigrade, and you are keeping the baby under the radiant warmer. And as I have already mentioned, you will be receiving the baby in a pre-warmed towel. So this is a pre-warmed towel, and you will be standing near the mother when the delivery is occurring. So if the baby needs to be taken from there, you will be receiving the baby in a pre-warmed towel. And as soon as you place the baby in the radiant warmer, you should position the baby properly. Positioning is the airway should be straight. As you know, the occiput of the baby is more prominent, so that when the baby is lying supine, the neck will be slightly flexed. That will result in obstruction of the airway. To avoid that, you need something called a shoulder roll of about 1 inch size, which is kept under the shoulder. So you can keep a shoulder roll under the shoulder so that the airway is straight. If the shoulder roll is too thick, that will again result in hyperextension and again will obstruct the airway. So position the baby, then you have to dry the baby. Along with that, you can see if there are secretions, you can apply suction. You know, the suction pressure is 100 centimeters of water, and you have to apply suction both to the nose and the mouth. Where will you apply suction first? So in the English alphabet, which letter comes first, M or N? It is M. So it is not because of that. Just to remember that you have to apply suction first to the mouth and then only to the nose. And you have to dry the baby thoroughly. So the towel should be fully spread. Otherwise, you will not be able to dry the entire body easily. So drying, and then you have to stimulate the baby. Stimulation. There was a time when babies were stimulated like this. Babies are kept like this and slapped on the back. So such things should not be done by any means. So there is no rod force of stimulation. The only way of stimulation is just flicking the sole twice or rubbing the back. You have already stimulated, because while you are drying the baby, you have already stimulated. If the baby has not tried by then, you can either flick the sole twice or rub the back for some time. So these much things you should finish in, and again you have to reposition the baby. And these is things you should do within 25 seconds, and the next 5 or 6 seconds you can assess the baby. That I will come. So I will just show how to do these things within a short period. So you have received the baby. So as soon as baby is kept here, I am positioning the baby. Then I am applying suction first to the mouth and then to the nose. Then I am drying the baby, and you have to give more importance to the scalp. Lot of fluid can be there and dried. And then important thing is you have to remove the wet towel and then keep the baby in another dry towel. You should not keep the baby in the wet towel for long. And then you can reposition the baby, and again you can stimulate the baby by flicking the sole twice. It will be just 25 seconds to do all these things. And if you can assess that, you should have a stethoscope. You can auscultate, or you can feel the umbilical cord for the pulsations. So you should not, usually you are taught to find out the pulse rate for 1 full minute. But as I have already mentioned, the time is counted in seconds. You think your head is immersed in a bucket full of water and someone is keeping the pulse and counting it for 1 minute. It is not acceptable. So you count it for just 6 seconds and multiply by 10. So that is how you have to assess. So you have to assess the heart rate, whether the baby is breathing, and what is the color of the baby, and then decide how to proceed further. So there can be a situation where the baby is breathing well, baby is crying, heart rate is more than 100, and good tone and color. So you need not do anything, you just monitor the baby further. If baby is having some labored breathing, still baby is having a heart rate of more than 100. In such cases, you can, if it is a term baby, you can just give oxygen and you can assess the pulse oximetry. If it is a preterm baby, you can start CPAP, continuous positive airway pressure. Then, if the baby is not apneic, baby is not breathing, or baby is breathing, but the heart rate is less than 100. So after the initial steps of resuscitation, if the baby is apneic, or even if the baby is breathing, the heart rate is less than 100, you have to start positive pressure ventilation. You should know that the most important cause for bradycardia in a newborn is hypoxia. So without correcting hypoxia, there is no point in chest compression and all. So even if the heart rate is 0 at this point, at the end of initial steps, even if the heart rate is 0, you will not be doing chest compression. You will be initiating the positive pressure ventilation. And regarding positive pressure ventilation, the important equipment you should be familiar is this ambu bag. So I think all of you have seen ambu bag. So ambu bag is a self-inflating bag, self-inflating. When I squeeze, it will come back to the position by itself. Self-inflating bag. The capacity will be roughly between 250 to 750. This is 500 ml. This is ideal size. And you should have face mask of appropriate sizes for a small baby. So an appropriate sized face mask means it will cover the nose and mouth completely, but it will not extend to the eyes and it will not go below the chin. So that is the appropriate size face mask. For depending on the size of the baby, the size of the mask also will vary. You should have the all sizes. And so this is the place where you attach the face mask. It will be tightly. And this area is called valve assembly. There are few valves here. One valve is you can see through the mask. This is called the fish mouth valve. When you squeeze, that valve will open. Fish mouth valve. You can see through this, or even without that, you can. I think you can see when I am squeezing, the valve is open. Fish mouth valve. And another valve is here. This valve is called pop-off valve. So when I am closing here and squeezing, the pressure will build up, and the high pressure should not be, the air with the high pressure should not be going to the baby. So to prevent that, there is a pop-off valve. So see, the pop-off valve is opening when I am closing this end. And this is the self-inflating bag. And here, in the rear end, you have two openings. This is the small opening where you can connect the oxygen. This is the large opening where you connect. This thing is called a reservoir. Reservoir can be either a bag like this, or it may be a long corrugated tube. Okay, so you have to check the ambu bag before the delivery occurs. One thing is, you see that it is self-inflating. If there are any damage here, it will not be inflating self. Then by closing, by squeezing, you should see that the fish mouth valve is opening. Then you should close here and see that the pop-off valve is opening. Then usually in a term baby, the resuscitation is started by room air. You need not provide oxygen, but depending on the response to the resuscitation, you will decide to give oxygen. And this reservoir helps in giving nearly 100% oxygen. So if the reservoir is attached, whatever oxygen enters here, partly it will be going to the baby, and the rest, if there is no reservoir, it will be going to the atmosphere. But if there is a reservoir, it will be collected here, and when you squeeze and release, the air from this bag will be coming, so that the percentage of oxygen will be higher. So that is regarding the ambu bag. And how to give bag and mask ventilation is, So baby is placed, the airway is straight. You can apply the mask by something like hooking from the chin. You can place it at the chin and you can, so now the nose and mouth is covered and it is not extending to the eye or it is not below the chin. And you should be standing straight. You should not be bending like this. You cannot give bag and mask ventilation for a long period by bending like this. So you should be straight and you should not be forcing, you will be tense sometimes. So you should not be forcing all your stress onto the baby. You can very easily produce a pneumothorax if you squeeze with your whole hand. So you should be squeezing with your fingers. And so you should obtain a good seal. So air should not be leaking from the side. So you should obtain a good seal and squeeze. How frequently you should squeeze? So when you are squeezing, you can say squeeze 2, 3. So when you say squeeze, you should squeeze. When you say 2, 3, you should release. So squeeze 2, 3, squeeze 2, 3, squeeze 2, 3. So that is how you should do. So if you do like this, the rate of breathing will be somewhere around 40 to 60 per minute. That is the expected rate. And you should be looking at the chest. So you are not looking at the face of the baby or somewhere else. You should be looking at the chest and see whether there is a chest rise. So you can see the chest rising slightly. I don't know how clear it is. So the chest is rising. So your pressure of squeezing should be just to produce a chest rise. You should not squeeze like this. Okay, so you should obtain a chest rise by squeezing with your fingers. So after 4 or 5 squeezes, if you are not seeing a chest rise and the other person who you are helping, he will be auscultating. If the heart rate is not improving, if you are providing proper ventilation, the heart rate will improve, the color will start changing to pink, and the chest will be rising. So if there is no chest rise and heart rate is not improving, that means your ventilation may not be adequate. So you should go think what is the reason. So there is something called MR SOFA, MR-SOPA, MR SOFA. That is for the ventilation correction steps. M is for the mask. So if there is no chest rise, you can reapply the mask and see that you have attained a good seal. R is repositioning the baby. Sometimes the position of the baby might have changed. See, here the shoulder roll is just here. So you can place the shoulder roll correctly and you can position the baby properly. So you have done 2 steps. MR you have done. You have reapplied the mask and repositioned the baby, and again you are starting to give positive pressure ventilation. So if there is no chest rise now, then you can proceed to S. S is giving suction. Sometimes there may be some airway obstruction, some secretion, so you can apply a suction. Then O is open mouth. You can resuscitate by keeping the mouth open. So MRSO. So you have applied suction and you are now keeping the mouth open and giving the ventilation. So and then if still there is no chest rise, you can go to the next thing, SOP. P is increasing the pressure. So you can slightly increase the pressure and see whether there is chest rise. Then the last thing, A is alternate ways of obtaining airway. It is mainly endotracheal intubation, and in certain cases you can use laryngeal mask airway. So that is what is called the MR SOTA. So only when you are successful in giving effective positive pressure ventilation, you expect the baby to improve. Once your ventilation is effective, you continue ventilating for at least 30 seconds and see how the baby improves. And one thing I forgot to mention is, as soon as you decide to give positive pressure ventilation, you ask the other person to attach a pulse oximeter probe on the right hand. So right hand is important because the saturation in the right hand gives the pre-ductal saturation. Saturation in the lower limbs will give the post-ductal saturation. Saturation of the left hand, you cannot predict whether it is pre-ductal or post-ductal. So you will be attaching the pulse oximeter probe on the right hand. And as you proceed with your resuscitation, you will be able to see the reading in the pulse oximeter also whether the oxygenation is picking up or not. Then after 30 minutes of resuscitation, there can be different scenarios. One thing is baby started crying, heart rate is above 100, cyanosis disappeared and all. Then you will gradually wean the positive pressure. So you were saying squeeze 2, 3, squeeze 2, 3, squeeze 2, 3. Then you will be decreasing the frequency. Squeeze 2, 3, 4, squeeze 2, 3, 4, squeeze 2, 3, 4, 5, squeeze 2, 3, 4, 5, 6. Like that, you will reduce the rate of breathing and gradually you will be weaning with this thing. And there can be a situation where the baby still is not breathing well, but the heart rate is less than 100, but it is more than 60. In that situation also, you continue with the bag and mask ventilation. After another 30 seconds, you reassess. So one problem with this bag and mask ventilation is, here you are giving, you are providing air both into the throat so that it can go in both ways. It can go through the trachea into the lungs, and it can go to the esophagus, and it can distend the stomach. When the stomach goes on distending, it will apply pressure to the diaphragm so that it will, the lungs cannot expand properly. So that will reduce the effectiveness of your ventilation. So when you want to give a prolonged positive pressure ventilation, bag and mask ventilation, you can insert a infant feeding tube, an esogastric tube into the stomach, and you can keep this end open so that the air will escape through that. That will prevent the abdomen getting distended and reducing the effectiveness of your positive pressure ventilation. So you should know how to insert a feeding tube. So you have to take a measurement from the angle of the mouth to the tragus, and from the tragus to the just below the syphistern. So this much has to go in. So you have to measure, and you have to keep it, don't forget to keep it open. If you are closing it, there is no use. So that is regarding positive pressure ventilation. And so that is thing. And then if there can be another situation where the baby is not breathing and the heart rate is below 60. So you have to remember two values here, 60 and 100. 100 is related to positive pressure ventilation. 60 is related to chest compression. If the heart rate is less than 60, you have to give chest compression. But remember, even if the heart rate is less than 60 or even 0, initially you have to start with positive pressure ventilation. And only after effective positive pressure ventilation for at least 30 seconds, you have to decide on chest compression. And chest compression, you have to do always along with the positive pressure ventilation. So you cannot do chest compression stopping the positive pressure ventilation. So you need two persons. So one person from this end will be continuing with the positive pressure ventilation, and another person from this part, this end, will be giving the chest compression. And remember, what is the purpose of this chest compression? You are now ventilating appropriately, so the air is reaching the lungs. But if the oxygen has to be, the blood has to get oxygenated, there should be good circulation. So if there is no circulation, your ventilation alone will not help the baby. So you have to see that the circulation is also maintained. For that, what you will do is, there are two methods. First thing, you have to find out where you have to apply. So the way is, you can run your finger along the costal margin. It will reach the syphistern. So just above the syphistern is the place where you have to compress. So you can either use two fingers like this. So if it is a preterm baby and all, you can use two fingers. But see, if the baby is on a cushioned surface, this pressure will not be effective. So in such cases, you have to keep your hand below the below the thorax of the baby so that you can squeeze like this. And another way is you can keep the baby like this between both hands and your thumbs. Your thumb should be vertical like this. And the thumbs should be placed here and you can compress. And whatever be the method, once you identify the location, you should not move the fingers from there. So it is not like this, one squeeze, then like this. You should not do like that. So whenever you reapply your fingers, it can change the position and it can cause fracture of the ribs, some laceration of the liver and all. So you have to place your finger properly, then you should not take your finger from there. And how much pressure you should apply, it should be at least, you should squeeze at least half of the anteroposterior diameter of the chest. So each pressure, each compression should generate a pulse, that is the dictum. Just applying some pressure is not sufficient. So the thing is, you should not hold too tightly so that it will prevent the expansion of the chest. Someone is giving bag and mask ventilation from here, so that should continue. And how to coordinate between this bag and mask ventilation and chest compression. So the total events in 1 minute should be 120. That means, and the ratio between ventilation and compression is 1:3. So for 3 compressions, 1 breathing. So the person who is giving chest compression will be saying it aloud. 1 and 2 and 3 and squeeze and. So when I say 1 and, I will be compressing 1. 1 and 2 and 3 and squeeze and. Squeeze and, when I say squeeze and, the other person will be giving ventilation. At that time, I won't be giving compression. So 1 and 2 and 3 and squeeze and, 1 and 2 and 3 and squeeze and, 1 and 2 and 3 and squeeze and, like that you continue so that it will be around 120 events per minute and the ratio is 1:3. And this has to continue for another 30 to 45 seconds and you should reassess. You should see. And another thing is, once you have decided on chest compression, so at that time it is always better to intubate the baby so that the ventilation will become more effective. And another thing is, by the time you are initiating chest compression, the baby should be receiving 100% oxygen. And as I have mentioned, for a term baby, you will be starting with the room air and gradually, depending on the response, you will give oxygen at varying concentration. In case of preterm babies, you will be starting with roughly 30% of oxygen and you will be increasing it based on the response to resuscitation. So that is, and other steps will be intubation. Indication for intubation will be one thing, you need ventilation for a long time. So it is always better, more convenient that you intubate and ventilate. For a short period, 2 to 3 minutes of ventilation, you need not intubate. But if you need it for a longer period, it is better to intubate. Another indication is when the baby is diagnosed as having diaphragmatic hernia. Sometimes antenatal scan might have picked up a diaphragmatic hernia. Or once a baby is born, you will notice that baby is having a scaphoid abdomen. Whatever content you expect in the abdomen is not there. So abdomen will be scaphoid. And usually the hernia is on the left side. So the intestine will be here fully occupying the left side and the heart will be pushed to the right side so that the heart sounds will be better heard on the right side. So scaphoid abdomen with the heart sounds better heard on the right side, you think the baby is having diaphragmatic hernia. In that situation also you have to intubate, because once you give bag and mask ventilation, you will be inflating the bowel within the thorax, which will further compress the lungs and the baby will develop severe hypoxia. So these are the two contraindications or indication for definite indication for intubation. And other things will be umbilical venous cannulation, and the indication for medication is if the heart rate is less than 60 even after 45 seconds to 60 seconds of chest compression. If the heart rate is still less than 60, you have to give adrenaline. Adrenaline can be given through the umbilical vein, that is ideal. Till getting the umbilical vein, you can give the initial dose through the endotracheal tube also. And another medication included in the neonatal resuscitation is normal saline. If the baby is in shock, maybe if you think that baby is in hypovolemic shock, you can give 10 ml per kg of normal saline as a bolus. So that is in short the how you resuscitate the baby. And you need at least 3 or 4 persons to complete the full sequence of resuscitation. So I want to highlight the importance of forming a team. And again, you should know how to decide. Decision making is important. So you should be always, you should have it should be pasted on the wall so that there should not be any confusion. Algorithm should be in the wall, and there should be a clock in the resuscitation area so that you know how much time it has lapsed. So that is in short. If you have any doubt, you can ask.
Yes, sir. We have got some questions, sir. Sir,
Yes.
why is the mouth first than the nose? You said no. N.
Okay. That's it is not because in English alphabet M comes first. It is just to remember. So suppose you are applying suction to the nose first. You know, baby is born through meconium, or there are a lot of secretions. When you put something in the nose, the baby will start sneezing and the baby will aspirate whatever is in the mouth. So always apply suction first to the mouth to prevent aspiration.
Okay, sir. Sir, another question we got. Sir, when do we use nasal bronze, or else we are using CPAP?
Okay. Nasal prongs is just a mean to provide oxygen, free flow oxygen. Free flow oxygen can be given usually during resuscitation. You give with the oxygen tube will be kept near the nose, and you will be holding it through here, like so that your cupped hand. So tube will be passing through your fingers. So with your cupped hand, you will keep it close to the baby. So that is the usual way of giving free flow oxygen. Or after that, sometime if you need it for a longer period, you can keep place an oxygen hood and give the oxygen. And if and in some situation you can give through the nasal prongs also. But the nasal prongs are not used during resuscitation. That is in the NICU when the baby is receiving oxygen for a longer period. And the CPAP is very important to prevent the respiratory distress syndrome in the newborn. If the baby is having breathing difficulty, a preterm baby, early CPAP in the labor room will prevent the severity of the respiratory distress syndrome, and it will reduce the need for giving surfactant or reduce the need for ventilation and all. So that is that has made a lot of difference in the outcome of preterm babies, early CPAP in the labor room.
Okay, sir. Thank you, sir. And sir, if heart rate is 0, should we use PPV directly, or what about checking the airways?
See,
Do we have?
usually we check the heart rate after 30 seconds. First you do the initial steps of resuscitation, that is positioning, suctioning, drying, repositioning, skin stimulating and all. And after that you will be checking the heart rate for 6 seconds and multiply by 10. So if the heart rate is less than 100, whatever may be the value, it may be 90, it may be 60, it may be 40, it may be 0. Whatever may be the value, you have to think that the bradycardia is due to hypoxia. So without correcting hypoxia, there is no role for chest compression. So you can just imagine you are not giving oxygen, the lungs are not getting oxygen, but you are just compressing the chest. It is not going to succeed. So first you will start positive pressure ventilation, if it is not effective, you identify it is not effective after few squeezes itself and go through the MR SOPA. And once the ventilation has become effective, you continue it for some 30 seconds at least, and then you assess. And if the heart rate is less than 60 at that moment, you can start chest compression along with ventilation.
Okay, sir. Thank you, sir. Sir, and another question came, sir, what does upper limb and lower limb saturation denotes?
Okay, so in resuscitation, we are checking the pre-ductal saturation. Pre-ductal, you know what is ductus. So ductus is a connection between the aorta and the pulmonary arteries. So always it is after the supply to the right upper limb. Sometimes, mostly it is after the supply to the left upper limb also, but not always. So if you want to get the pre-ductal saturation, you have to look at the saturation in the right upper limb. So that is why you are looking it in the right upper limb. Lower limb saturation gives always the post-ductal saturation. So during neonatal resuscitation, you don't look at the lower limb saturation. But this lower limb saturation has got importance in pulse oximetry screening. At 24 hours of life, you check the pulse oximetry values of all newborns. If a baby is having a critical congenital heart disease, you can have a SpO2 value of less than 90, or you can have a value more than 90, but the difference between pre-ductal and post-ductal is more than 3. In these situations, even if it is less than 95 also, you should be careful. In these situations, you will examine the baby in detail, and you may do investigations like echo to rule out a critical congenital heart disease, which can cause worsening once you send the baby home. Baby may die, or baby can arrive to the casualty in a critical stage if you are not identifying it before discharge. So that is the role of pulse oximetry screening, which is done in all babies now at 24 hours of life.
Okay, sir. Thank you, sir. And sir, one more question came. Sir, will you please explain the reasons for heart rate to be less than 60 in neonates?
It's not a reason. See, I was mentioning about what is primary apnea, secondary apnea and all.
Yes, sir.
So primary apnea is the initial stage. So suppose you think a baby is having distress in utero. So initially baby will have fast breathing. Then after some time baby will develop apnea. And at that time the heart rate is almost normal. But if the problem is not corrected in time, or if the delivery is not happening by that time, baby will develop some irregular breathing. After primary apnea, baby will start breathing again, but it is some irregular breathing. And after some more time, baby will develop apnea. It is called secondary apnea. In the secondary apnea, the heart rate will be less, and it can be even less than 60, or even it can be 0. The heartbeat may stop. See, so some of the babies delivered at this time will be born stillbirth. Baby will be dead at that time. And in some babies, at that time, you may have to revive. So initially, you will be doing the initial steps, then you will be giving the positive pressure ventilation, thinking that if you give positive pressure ventilation, baby will come around. But if it is not happening, so that decision you will take at the time of 1 minute of life. 30 seconds you have done the initial steps, and another 30 to 40 seconds you have given the positive pressure ventilation. By around 1 minute or so, you will be deciding to give chest compression also along with positive pressure ventilation to improve the circulation.
Yes. Sir, another question. How do we manage a meconium stained baby?
Okay, so that part I forgot to mention. So there are a lot of changes happened in the management of meconium stain. Babies born through meconium stained amniotic fluid. You know, meconium, usually babies don't pass meconium in utero. So early passage of meconium in utero denotes fetal distress. And these babies, the meconium will be there in the airways. So what previously we were doing when I was doing my MD and all in 1993, 96, what we do is we will stand with the mother during delivery. As soon as the head is born, we will apply suction to the mouth so that maximum meconium is retrieved before the the first breath is taken to prevent it getting aspirated. So that was the dictum some 20, 25 years back. Then it was, our system of medicine is evidence-based, isn't it? So we will rectify whatever wrong things we are doing. So a lot of studies have shown that there is no much evidence favoring this aspiration of meconium while the head is born. So people waited till the baby is completely delivered. And if the baby is vigorous, baby is crying, breathing and all, you don't do anything. But if the baby is depressed, you do the intubation. You before baby is breathing, you straight away intubate the baby and take out whatever meconium is possible. So that was the dictum till a few years back. And again, various studies shown that there is no much evidence favoring this intubation, even in depressed babies. Depressed baby means baby is not breathing well, baby is floppy, hypotonic and all. So even in depressed babies born through meconium, there is no evidence favoring intubation and suction. So that practice also changed. And now, even if the baby is born through meconium stained amniotic fluid, whether baby is vigorous or depressed, you do the routine care itself, early initial steps of resuscitation, and then you give the bag and mask ventilation. Only if you feel that the airway is obstructed, you give intubation and suction. So that is the practice nowadays.
Okay,
Is it
sir.
clear?
Thank you. Yes, sir. Yes, sir. Thank you, sir, for clearing the doubts. So I think session has come to its end. So I would like to thank all for joining us, and let me express our sincere gratitude to Mohandas sir for enlightening us on the, neonatal care and sparing time to share this. And thank you, sir, for demonstrating the same and sharing the information in very simple language. Thank you very much.
I was not very sure whether I will be successful in demonstrating because these technologies are really difficult. It is actually shown to a small group of students standing around. I am doing this for the first time, thanks to COVID.
Yes, sir. Thank you very much, sir. So thank you all once again. Thank you, sir.